Welcome to another episode of Women in Research. I'm your host, Nekesa Esther, and I will let our guest of the day introduce herself. Welcome, Prof.
Thank you, Nekesa. My name is Professor Sylvia Opanga from Faculty of Health Sciences, specifically Pharmacy. And I'm very happy to be here today.
Welcome. We're also excited to have you on board. And as you can hear, I have a flu, so you'll tell us the things that I should be doing, you know.
Yeah.
So anyway, Prof, of course, it's interesting. When I was told you are Prof, when I was told the news, I was like, wow, I was told you are almost the youngest Prof, in that faculty. So can you slightly tell us about that, about your journey?
Yeah, my journey started pretty much after undergraduate, because after my internship, I just came back to the university for my master's immediately, so I did not practice out there for long. I came back for my master's, and during...
So wait, you did medicine?
I did pharmacy.
You did pharmacy.
I did my bachelor's in pharmacy and then my master's in clinical pharmacy. So immediately after my undergraduate, I came back for my master's after my internship. And then after that, during my first year of master's, towards the end of my first year, I was actually picked up as a tutorial fellow.
Oh, nice.
And I've been in the university ever since.
All right.
So worked through that, then into my PhD, finished my master's and into my PhD, then did quite a lot of research as well as a postgraduate fellowship. And I'm here now.
Wow.
Yeah.
Congratulations. How long in terms of years?
Within, between the first time I was employed as a tutorial fellow and now it's about 10 years. So it's been 10 years of grueling hard work.
Yeah.
Yeah.
So have you been studying and learning? This is just for my curiosity before we go into the details of the research.
Yeah, I had to combine my work as a tutorial fellow and as a lecturer going up to the ladder, as well as pursuing my PhD and my fellowship and all the way to professorship, including international collaborations, including my work in innovation, including publications, which up to this point, I think there are more than 100 at this point.
Oh, nice. So what do you focus on?
I love patients. So my number one passion is patient care, and basically to think about how can we make medicines safe for patients. In the pharmacy profession, we always say medicines are poisons. Because they have, much as they cure you, they also have their adverse effects. And it's upon me as a clinical pharmacist to review all the patients and just make sure their medicine is safe and it's effective. So that's my number one passion and my number one focus. And a lot of my research is actually based around drug use in patient populations, especially those with infections and those with non-communicable diseases like diabetes, hypertension, liver disease, kidney disease, cancer. Yes.
So how did you end up there, Prof, in terms of finding out exactly, how did you end up in patient care as your passion, zeroing it in as your specialty?
Yes, as I can say, first of all, pharmacy is very diverse because there are different branches of pharmacy. There are those who specialize in industrial pharmacy, where you discover drugs and formulate them. Do you, if you look at a drug, is it, will you make it into a syrup, a tablet, or a capsule? So there's the whole industrial and drug discovery part of it. Then there's the clinical pharmacy, which is focused on patient care. And then there's even traditional medicine. And then there's pharmacology. So my passion for patient care started when I was an undergraduate, under the heavy mentorship of the late Professor Opanga. So he actually ignited a passion in me to start clinical pharmacy and my love for patients also. Yeah.
So what are some of the findings as you're going through your work and through the research? What are some of the things that, for instance, you've said you've published? Over 100 publications are out there. What are some of the things that you can tell us that, you know, can impact someone like me?
Okay,
good. The regular person.
A lot of research that I have done focuses on when you give a patient medication in a hospital care setting, what are some of the medication-related problems that we diagnose and resolve? a lot of times when you go through prescriptions and patient treatments, you find that sometimes the patient has been given medication, there's a prescription, the patient is not taking the medicine. You can have what are called drug interactions, where you have patients being on multiple medications. Some are interfering with the work of each other and reducing effectiveness. Those are some of the glaring findings. Some of the medication-related problems we also have realized is that you have patients having overdoses or underdoses. You have adverse drug reactions that happen. So it has really spurred me as a pharmacist to think, what are the kind of solutions that we come up with to resolve these medication-related problems? Because sometimes you find patients being treated, being cured, but at the same time, they are suffering adverse drug events, which can actually kill them. So a lot of my research has revolved around that in infectious disease and non-communicable diseases.
All right. Wow. I'm impressed. I'm just trying I'm trying to think. I'm thinking as you're talking. So how then do you do your research? Do you have a few patients that you follow, that you study? Or is it from a pharmacist side? In terms of why I'm asking this is so that I just want to understand then whose responsibility is it? Is it the doctor's responsibility, the person who prescribes? Is this the pharmacist, or is it the patient's responsibility to bring change if there is?
It's a collective responsibility. Yeah, because the doctors are highly trained in diagnosis. We as pharmacists are highly trained in medication, from drug discovery all the way to patient use. The patient is also supposed to be aware of their medication and reach out to the doctor and the pharmacist. So it's a collective responsibility. We bring all our specializations together. We always work collaboratively with the medical doctors and pharmacists in the same way we are trained together. Yeah, so we always work in collaboration. We go for ward rounds together, we review the medications together and come up with a solution. So we always work hand in hand.
Yeah. So what are some of the innovations? You've talked about innovations that you've worked on.
Yes, yes.
And what are some of the things that you're working on right now?
Okay. Several innovations, and at the moment I like involving students. We sit down and brainstorm and come up with innovations. So one of them, the first one we actually did during the COVID pandemic, we studied diabetic patients. During the COVID pandemic, diabetes was actually associated with worse outcomes. If someone had diabetes and COVID together, there were worse outcomes, a lot of morbidity and mortality. And because of that, patients were refusing to come to the clinic. You know, I'm diabetic, I'm supposed to go for my review and my refill of medicines, but what if I go to Kenyatta and get COVID? What will be my outcomes? So we had a drop in patients reporting to the clinic, and we thought around it and we said, how do we reach these patients? We developed a telemedicine app for that, and we tested it among patients and the doctors and pharmacists working at that clinic, and we were actually able to help the patients access their care through that. So once we validated that through patients, then we have built it up into a massive website and an app where you have all caregivers reaching out to patients. For example, some patients are stable and they're always told, go home, come back after a month, we do your review, come back after 3 months, we do your review. But between releasing the patients to go for 3 months, what happens in between? Nobody knows. And so we are training our patients now to take their blood glucose, enter into the app. If they feel, we are training them to also think about recognizing the danger signs. For example, if their blood sugars are not very well controlled, they can just put a red flag. There's an option for that, and we can be able to admit them quickly if it's an emergency, or bring the review forward so that they don't really have to wait. In this app, we also do medication reviews. You see, some of these patients could be diabetic, also suffering from kidney disease, hypertension. They always come with a lot of complications. And so we are able to talk them through, this one is for diabetes, this one is for hypertension. The one for hypertension can also help with your kidney disease. So we do a lot of education. We also tell them about adverse effects they can expect. And if they're having a lot of adverse effects, how do we switch that medication? So we are in constant touch with patients. That's the first one. Another one we are working on.
Let me just ask a question.
Yes.
Is it free for all parties, or they have to pay to access that?
For patients, it's free, but for, you see now we are now commercializing this to hospitals and clinics and other institutions. So those ones have to subscribe.
And what's the name of the app?
It's called Consult Ease.
Consult?
Consult Ease, like ease of consultation.
Oh, Consult Ease.
Yes.
Wow.
Yeah.
Okay. Do you want people to know about it? Consult Ease.
Of course,
yeah.
yeah.
Okay.
Because now we are expanding that. We've been very successful with diabetes. How will we be able to leverage on that to think about cancer patients, patients with hypertension, kidney disease, and other chronic illnesses? Yeah, so that there's continuity of care.
That's good. You were going to say another innovation.
There's another one which is still in the very primary stages. It's called Arakonika, where we actually use saliva samples for early detection of breast cancer. I'm not able to talk about it right now because it's still in the primary stages. The third one we are working on is called Dawa O'Clock. So Dawa O'Clock is a device which also has an app which reminds patients on how to take their medicines, when to take their medicines.
Nice.
And then we have a pill dispenser connected to that, so that once your time reaches, the app connects, the pill is able to pop out of the pill dispenser.
All right.
Yeah, so
but it's an app.
It's an app and a device which are interconnected, so that on the app, if your time for taking medicine comes out, it programs the pill dispenser to dispense your pill, so that you don't have confusion with timing. A lot of times people are too busy. They forget to take their medicine. Sometimes people have lots of medicines. They don't know, do I take this one with this one? Do I take this one with another one? And we always have a pharmacist to guide the patients on that.
I'm laughing because I'm a victim. Recently, I was given medicine and I was told to take 1 times 4. And I was told, just take after every 6 hours. So I found myself sometimes taking after 4 hours, after 6 hours. And I'm like, this thing.
Yeah.
So I'm told within 24 hours, take 4 tablets. After every 6 hours, I'm supposed to take a tab. But after every 4 hours I take, I'm like, is it 4 or 6 or?
Yes.
There was just a lot of confusion. And that was just one.
Yes.
So
and you can imagine
someone
who has 8 medicines on a prescription. They're having diabetes, kidney disease, and hypertension together. There's a lot of confusion. Even sometimes the drugs are colored differently. Sometimes you get a generic of the same brand and it's confusing. So we are able to actually prime that and tell the patients, and we arrange them in pill boxes nicely. The red pill is for this. You take it at this time. It will prime you. So it's helped us to actually avoid some issues with dosing. It's helped us to avoid some issues with drug interactions, because if we know drugs are interacting, we will time them differently so that they are cleared from the body before you introduce another one. Yeah.
So, Daktari, take us back. Let's go back and tell us how your dream started. How did you always envision yourself being where you are?
Well, I think so. And I had this battle with my parents because my parents, when I was in high school, they were insisting, go and do medicine. But I thought, medicine is very mainstream. Everyone knows medicine. People know very little about pharmacy. And I was very interested in just showcasing what pharmacy is. And one time when I was a little girl, I was taken to a clinic, and then after the clinic, you go to buy medicines. So at the clinic, you just find a bed, and then they examine you and they tell you to go. And then going into the pharmacy, I see these different colors of medicines, an array of medicines. It's just looking beautiful. And I was like, I don't want to just sit there with patients on a bed, niwapime, then I go. I want to do much more. Yeah, and so I decided I'm going to be a pharmacist when I was in Form 3.
Oh, nice.
And yeah, my parents were like, no, take medicine. So on my mother's side were people who have done medicine. On my father's side are people who have done pharmacy. So you also compare and you're like, where do I want to go? And I settled on pharmacy.
Yeah, 'cause
but
about
my
to-
parents both were, no, take medicine, take
Yeah.
medicine.
Yeah.
So I juggled between, if I do medicine, I'll be a cardiologist, or I'll be a clinical pharmacist. One other thing that made me not do medicine, because I qualified for both, I didn't like the surgery part and wounds
And
that
you have to go through the whole...
Yeah. We went through anatomy classes. That's the first thing you do when you come into first year. Chiromo, dead bodies, cadavers, you're operating. That I didn't like.
Wow.
Yeah, so I settled for pharmacy.
Wow. And going on as a researcher, then did you see this part? You know, there are people who studied and they went on to work. I'm sure you have your classmates who, you know, they, after you have your degree in pharmacy, you already, for us, we already consider you, you know, you've qualified and all.
Yeah.
So how then did you get into the research part of it?
Research comes with academia, very automatic. Yeah, you cannot be in academia without doing research. And I loved research because I love to solve patient-related problems, especially when it comes to drug use. So when I joined my master's, I threw myself into research. I worked quite a bit when I was a master's student with Kemri Wellcome Trust to see how we were using the current evidence base to actually promote and develop guidelines for pediatric use. I worked with the team in Kemri Wellcome Trust doing that, what we call evidence-based healthcare. And that just strengthened my resolve to jump into collaborative research. Yes.
Oh, wow.
Yeah.
I'm learning, Prof. And I remember before the camera started rolling, there's something you mentioned to me, and I said I'll ask you. It escaped my mind.
About antibiotics?
I think so. We've talked about it, yes. We've talked about, yes, that's one of the things we've spoken about. And in terms of making a change, making an impact in society. At the end of the day, I know, and I totally believe that research and research output is supposed to change, you know, change lives in our society. And that's what we keep saying we do here. So how does your day-to-day, you know, either career and or research transform lives out here?
So I will look at it in different angles. In terms of policy, I work a lot with the Pharmacy and Poisons Board, which is our regulator. And through the Pharmacy and Poisons Board, we have been able to come up with pharmacy practice guidelines. And with pharmacy practice guidelines, we are able to now get rid of these problems that we are having, including people purchasing over-the-counter medicine, prescription medicines over-the-counter, people purporting to be pharmacists trying to treat patients out there in unlicensed premises. So we have already come up with those guidelines, and I think we are launching them next month. And then we start enforcing them. I also work with the Ministry of Health, and that, of course, will impact how patients take their medication. In the Ministry of Health, I'm part of what is called the Antimicrobial Stewardship Working Group. So what are we doing? We are promoting proper antibiotic use. And I'll just laugh at you because you told me you've been taking antibiotics for your cold and cough.
Self-medication.
Self-medication. So we are working together with the Ministry of Health to just see that patients take antibiotics when they are required to take antibiotics. And pharmacies do not just dispense antibiotics to anyone. We're also looking at how do we engage communities in and just educate people out there. You don't need an antibiotic when you have a cough and cold, for example. Just take your dawa,
Yeah.
take a cough syrup or something, take a painkiller, hydrate, and within 7 days it's gone.
Oh, wow.
Yeah, so those are some of the initiatives we have at the Ministry of Health.
Yeah.
Back to the patient level in Kenyatta, we do what is called medication therapy management. So we move from patient to patient, reviewing prescriptions, taking their history, seeing if they need additional medication, whether we can adjust doses. For example, people with renal disease, liver disease, you always need to adjust doses downwards because they're not able to excrete or metabolize the medicine. So we work out, there are formulas we used to work out to adjust medicines. Looking at the pediatric population again, dose adjustment is important. The very old patients, we are not likely to benefit from the same dose because they are very old, their organs are failing. So those are the kind of things that we're doing, just tailor-making medicines to patients so that we don't have a blanket dose for everyone. It never works that way.
Yeah.
A new field that I'm trying to launch into right now is called pharmacogenomics, where we use your genetics to actually tailor-make your doses and your medicines for you.
Wow.
There are some people, depending on your genetic makeup, your body will resist a drug and you'll have a lot of drug effects. Some of them, depending on your genetic makeup, you might benefit very well from one medicine. And that's why you see someone with diabetes can be given the same medicine, but they react differently. And we've come up with research that shows it's your genetics. Genetics also affect how you break down the medicine and excrete from your body. So that's one of the big areas of research I'm trying to follow up right now. And it will really help in medication safety, preventing adverse events, and also just making sure patients get the right medication tailored to their genetics.
Wow, that's powerful.
Yeah.
I would love to see that. What can you comment on about, you've mentioned something which has piqued my interest. There's a lot of these pharmacists in our estates, and they have a lot of locally manufactured drugs or alternatives to the drugs that we know.
Yes.
What can you comment on about them? Should we trust them or not? Because sometimes you ask someone for some certain medicine and they give you a completely different one, and they convince you that that is the same as what you're asking for.
Yeah. So the problem might not be with pharmacists, but the issue here is Kenya is a free market. And different medicines, this is how medication goes. When a medicine is discovered, you have the parent manufacturer of that drug who has discovered the medicine. They're given a patent period of, I think, around 20 years to be able to recover their costs and market the drug exclusively. Okay? And they have a patent. Once the patent expires, then it allows for other drug manufacturers, including the local ones, to make the same molecule. They could package it differently. The tablets might look differently. The packaging might look different, but the same molecule is the same. Yeah, so that's why sometimes you see, you will have amoxil that is called penamoxil. You'll have amoxil that is called coamoxib clav. You'll have different trade names, same molecule. So what you need to always look out for, is this the same molecule? Yeah. And on the other hand, you also have a problem where sometimes you have medicines that are counterfeited. So people actually counterfeit medicine and sell it and package it like the same medicine. Actually this week I was very saddened to see that there are counterfeits in the market for a breast cancer drug. How evil are people? But the good thing is that the Pharmacy and Poisons Board has stopped that batch from spreading in the market. So this calls for very tight regulation. And the other thing, mushrooming of pharmacies all over the estates is also a problem, because some of the people in pharmacies are not qualified to run pharmacies. And for the Pharmaceutical Society of Kenya, we have what is called the Green Cross Initiative, which will actually tell the public that this is where you have a licensed pharmacy, a pharmacist who is licensed and trained, their picture will be hung on the wall and the license, and that's where you have to go. If you don't see any of that in a premises, run, sister, run.
When does that start, or it's already ongoing?
It's an ongoing initiative, and I think within the next few months we should be able to roll it out.
That would be so good.
Yeah.
You said something about counterfeit drugs for breast cancer, and I was concerned. How do you guys pass your information? Like, how does that body, the regulator,
yes,
then communicate to? I feel like this should be, everyone should know.
They always do press releases. They usually do a whole page of a newspaper. So if you look in some of the newspapers this week, that is there. And I think that was also, they also use their social media to spread that information.
But there's definitely need to talk more about, because nowadays, I mean,
if someone can counterfeit a cancer drug, what about an anti-malarial? What about an antibiotics? What do we have in the market? So we need very tight regulation on that.
Wow. Yes, there's need for a lot of sensitization and communication
and
on
the
that.
other thing that's coming up are online pharmacies. That's a disaster.
And the way we love buying everything online.
I actually I was doing some random research on online pharmacies just 2-3 days ago. And I just decided to log into online pharmacies and see. I went to Uber Eats. They have some online pharmacies there. And I'm just trying to find out, what do they sell? First thing, sexual products, Viagra, contraceptives. I'm like, these are prescription-only drugs. Viagra was actually initially developed for hypertension within the pulmonary system. So you see, it will still drop your pressures. You hear some people have gone on their escapades and someone dies.
Also, it's supposed to be prescribed.
It's supposed to be prescribed. You can't just buy it over the counter. No. Even contraceptives have serious side effects on women. They have serious side effects because of the estrogen and progesterone. But you have people selling P2 over the counter, very high levels of progesterone called levonorgestrel, and they have an effect on your reproductive system. They can affect your blood clotting so that you start clotting unnecessarily. They can affect your cardiovascular system. They have a lot of adverse effects. So information to be passed to young girls.
They're supposed to be prescribed?
Yes, not to be bought. And actually one of the innovations we've just reminded me we've come around is we have an app called Whisper. So you see the way you talk about sexual and reproductive health among the young people. Sexual and reproductive health, people tend to treat it as a very private issue. And people don't, for example, in a pharmacy setting, people can't just come and start talking about those
You can't just enter and say, I want P2.
Yes.
You wait for everybody to leave.
Everyone to disappear. I've worked in pharmacies and I know.
So you know.
They wait. And so we are thinking, we have an app called Whisper, which they can come and whisper to us, what do they want to talk about? Yes.
So have you ever sold someone P2 without a prescription?
No.
No. You refuse?
I don't do those things. I'm very professional.
Professor.
And in fact, the profession of pharmacy knows me as a very tough cookie. I don't entertain those kind of things.
All right.
Yes. Because I'm a patient
Can you comment about
advocate.
our student clinic? Do you know what goes on down there?
Well, I can't really comment on what goes on there.
Have you ever checked? Have you ever been curious?
In fact, you're reminding me of another innovation that we have. Oh God, we are innovating around all these problems. So we have an innovation that actually won last week among the hackathoners called Campo Care. Campo Care is a website and app which will be used to digitize student information, the same way the staff clinic is. We digitize that information. We also include patient information just to talk to the students about their medication, to advise them what to do. They can whisper to us as well. So Campo Care is one of the innovations we have around that. And I think when you think about reproductive health issues and other issues that students are having, ingraining this into the student student clinic can actually help us to solve some of those problems. We are looking to actually speak with the Vice Chancellor on how can we ingrain this within the student clinic system. Yes,
Thank
it
you
will
so
really
much,
help.
Prof. I have learned so much myself. I don't know how you feel. Do you feel like you said everything that there was to say about your journey in research?
No. There's so much to say because when you look at medicines and diseases, I think we need a lot more conversation because you just realize there's so much. This is just a tip of the iceberg.
Yes.
There's so much that we need to talk about in future.
Yes,
Yeah,
for sure. I hope you can come back sometime.
Yes.
And
I'm a phone
give us,
call
you
away.
know, like you just take us through some of the things that we need to learn. Because I've learned, I have learned, honestly, I had no idea. Antibiotics, when you have a flu, I'm a victim.
You see,
I didn't know that.
A flu is viral.
Yeah.
An antibiotic is for bacteria. So why are you using medicine for bacteria to treat a virus? It won't work. A normal flu, whether you take whichever drugs, it will stay with you for 7 days and go away. So we use what we call symptomatic management. We manage your symptoms. If you're having a headache, if you're running a runny nose, if you're having a blocked nose.
To treat all these other things.
Yeah. Yeah, so a lot of hydration. Take painkillers if you have a headache, you know. Yeah, if you're having a runny nose and a cough, take a cough syrup or something. It will go away. So we manage the symptoms because a lot of viral infections will just go away. Yeah.
Wow. Thank you so much. Do you have any parting shot?
Parting shot, patient safety. Look out for what you get in pharmacies. If you go to a pharmacy, ask a lot of questions. Ask, because what we always say, patients are entitled to know what you're giving them. You know, we just don't write prescriptions for you and kunywa moja mara nne or something like that. People should actually be able to educate you a lot more on the medicines that they're giving you. So if you're going to a pharmacy and nobody's able to educate you, run. They're supposed to tell you about your medicines. You have your right to know. Yeah.
I like that. The running. Guys, we've been given so many warnings. I have learned so much. I feel like this is a very packed, you've given us so much information in such a short time. We should definitely come back. Thank you so much for coming.
Karibu sana Nekesa.
And thank you so much for watching, guys. I hope you've learned as much as I do. You can leave your comments here, like, subscribe, share, and have a good one.
UNC TV, empowering you.